You're listening to Clinical Conversations. Last week, the EPCAT II investigators published the results of their trial comparing the effectiveness and safety of aspirin versus rivaroxaban as extended prophylaxis against venous thromboembolism after arthroplasty. An editorial in the New England Journal of Medicine called the results, quote, likely to be practice-changing, end quote. Here with us to discuss those results is the study's first author, Dr. David Anderson. He's at Dalhousie University in Halifax, where he serves as Professor of Medicine and Dean of the Faculty of Medicine. Welcome to Clinical Conversations, Dr. Anderson.
Thank you.
We needn't go into too much detail here, but let me try to summarize. You randomized about 3,500 patients undergoing total knee or total hip arthroplasty to extended prophylaxis with either aspirin or rivaroxaban after they'd received rivaroxaban for 5 postoperative days, correct?
Correct.
Okay. And then you compared the frequency of symptomatic venous thromboembolism and bleeding episodes between the two groups during the 90 days after randomization.
That's correct.
Okay. So now I'll let you talk. Tell us what did you find?
So we found in the study that really the two groups performed very similarly, that there were low rates of thromboembolic complications in patients randomized to aspirin and rivaroxaban, and there were very low rates of major bleeding complications in the two groups in the 3-month following surgery.
Okay. And so aspirin, you found, was non-inferior to rivaroxaban, but not necessarily better.
That's correct.
Okay.
That's correct. So I'd say comparably effective and safe for this indication following hip and knee arthroplasty.
Okay. And I know that in the earlier trial, the EPCAT, we'll call it EPCAT I, you compared warfarin and aspirin.
So it actually was dalteparin, the low molecular weight heparin dalteparin, and aspirin after total hip arthroplasty.
Okay. And you had similar results in that trial?
Yes. So we had similar results with that trial, and we ended up, that study got stopped early basically because the new oral anticoagulant agents became commercially available, and we felt that the relevance of that first study had lessened as a result of that practice-changing innovation, and that led us to the design of the EPCAT II, or the more recent study.
Okay, so that must have been at the advent of the bigatran and rivaroxaban. Is that right?
Right. That's right. The new oral anticoagulants are new at the time.
Okay, so for this comparison that you've just published, why did you make this comparison, and why was it important to make?
Yeah, so we really, there were two innovations that we thought were important to do in this study. Is one, we wanted to have a strategy following both total hip and total knee arthroplasty. So we wanted to really look at whether this was a generalizable strategy after each of the two major lower limb joint arthroplasty procedures. Uh-huh. And the other innovation that we did is we wanted to shorten the initial course of rivaroxaban therapy to a time that we would consider early phase or in some situations the in-hospital phase of perioperative anticoagulation following these procedures, and then look at the comparison of aspirin and rivaroxaban for the extended phase of anticoagulant prophylaxis, which generally occurred outside of hospital. So we pushed the boundary a little bit from our first study from 10 days of prophylaxis to 5 days, and then added a knee replacement cohort in addition to a hip arthroplasty cohort.
Okay.
And we designed the study with the expectation that we would have large enough patient cohorts that we would be able to make some comment about the comparability of aspirin and rivaroxaban following each of the arthroplasty procedures, as well as having the combined result.
Uh-huh. And so for the knee, you did 9 additional days, and for the hip, you did 30 additional days.
That's right, and that really reflects what was done in the research studies that resulted in the approval of rivaroxaban following hip and knee arthroplasty, and what guidelines have recommended about extended prophylaxis, which seems to be of more value following hip arthroplasty than knee arthroplasty. So those time courses would be consistent with previous studies and guidelines.
Okay. So tell me, were you surprised to hear or read that the editorialist called your study practice changing?
No, I wasn't surprised to hear that. I think for orthopedic surgeons that are routinely using one of the direct oral anticoagulants now for prophylaxis following surgery, that this would be a very straightforward transition for them to make to switch at 5 days to aspirin following total hip or knee arthroplasty.
Okay. And have you changed practice at Dalhousie already?
So we have again that the surgeons were very keen to make this change, and certainly I expect it will be happening at our other sites across the country as well.
And the clinical differences between aspirin and rivaroxaban were not. They were equivalent, essentially, for what you were looking for, and so the important outcome here, looking beyond the patients, of course, is the economic outcome. So I wanted to ask you whether anyone had done any back of the envelope calculations about the number, the amount of money that could be saved, either per patient or in the system, by going to aspirin over rivaroxaban.
Yeah, so we've done I'd say a back of the envelope calculation, as you've said, Joe, that given that rivaroxaban costs dollars a day and aspirin costs pennies a day, and given that arthroplasty is one of the most common surgical procedures done in first world countries, if you look at a country like the United States, where there's up to 1 million of these procedures or more done in a given year, it is getting into the multiple tens of millions of dollars per year that are going to be saved with this conversion.
Okay. And there's another study, and it was mentioned by Alan Brett in Journal Watch when he was reviewing your study. He said that there's another study that's examining using aspirin, warfarin, or rivaroxaban for 30 days from the start. In other words, your study used 5 days of rivaroxaban. And then you randomize the patients to aspirin or continuing rivaroxaban. Did you consider using aspirin from the start, why would you not have?
Yeah, so we did have that discussion with our orthopedic team. And following the completion of our initial study, which looked at low molecular weight heparin versus aspirin in a comparable fashion, we had the discussion about should we just go to a head-to-head study or use the approach that we used in EPCAT II. And I think really it was our orthopedic surgeon investigators were not comfortable that there was enough evidence to support the institution of aspirin at immediately after surgery, and felt this this approach, which pushed the envelope a little bit by shortening the duration of rivaroxaban prophylaxis and expanding the study to involve knee arthroplasty patients as well, would give us some very useful information. So we would agree that I think at this point, and with the results of the EPCAT II study, that a head-to-head study of aspirin and one of the direct oral anticoagulants is warranted.
So you were pushing the envelope, but you didn't want to break through the envelope, and I guess that's understandable.
Yeah, I think it was a very thoughtful decision that was done by and it really was driven by the orthopedic surgeon investigators who played a very obviously an incredibly pivotal part of this study. It was we discussed it, and at the end of the day, the surgeon is the one that's accountable and takes responsibility, and we made a very thoughtful decision as a research team.
Dean Anderson, I want to thank you so much for talking with us today.
Pleasure.
That was our 217th edition. All earlier conversations may be found at podcasts.jwatch.org. We come to you from NEJM Journal Watch. Kristen Kelly is the executive producer here for the NEJM Group. I'm Joe Elia. Thank you for listening.